Hey everyone, and welcome back, focused learners. We are jumping right into another high-yield CPC exam explainer today. In Part 12, we're mapping some incredibly complex anatomy directly to actionable coding frameworks. But before we get rolling, make sure to like, share, and subscribe to Decode Healthcare with Harshal so you never miss out on these essential coding strategies. So, I've got a huge question for you right off the bat. Do you know the exact coding difference between the central nervous system and the peripheral nervous system? Really take a second and think about it. Mastering this distinction, well, it isn't just a flex of your anatomy knowledge. It is absolutely make or break for passing the CPC exam. All right, here is our syllabus for today's system-by-system clinical tour. We're covering endocrine anatomy, endocrine disorders and procedures, nervous system anatomy, that critical CNS versus PNS coding difference, neurological procedures, and wrapping it all up with a Part 2 cheat sheet. Section 1, Endocrine Anatomy, top to bottom. Okay, let's dive into this top-down spatial approach to mapping out the endocrine system, which, as you know, is all about hormone regulation and systemic effects. You know, picturing where things actually live in the body, that spatial anchoring is a massive game changer for your memory on the exam. Notice how we just divide it all into regions? Up in the neck region, you've got the thyroid, which regulates metabolism using T3, T4, and calcitonin. Right beside it, literally right there, are the 4 parathyroids, and they manage your calcium balance via PTH. Then drop down to the abdominal region. Here we find the pancreas, taking care of glucose with insulin and glucagon, and the adrenals handling stress and salt balance using cortisol, epinephrine, and aldosterone. So, when you see documentation about a cortisol imbalance, your brain should immediately jump straight to the adrenal glands. That guides you directly to the correct endocrine chapter in your ICD-10 CM manual, rather than just aimlessly flipping pages.
Let's build on that a bit by adding the pituitary and gonads into the mix. In medical coding documentation, you're frequently going to run into the downstream systemic impacts of these glands. For instance, a growth hormone deficiency triggered by the pituitary gland will completely dictate how we assign our diagnosis codes for various metabolic and reproductive disorders. It requires a totally different code set than a primary target organ failure.
Section 2, Endocrine Disorders and Procedures. All right, shifting from normal anatomy to pathology. Just remember that CPC exam multiple choice questions absolutely love testing your ability to differentiate between opposite conditions. Now, what's really interesting about this slide is how overactive versus underactive disorders completely flip the clinical severity and, by extension, your resulting ICD-10 CM code. Look at hyperthyroidism versus hypothyroidism, or take Cushing's disease, which is an overproduction of cortisol, versus Addison's disease, a life-threatening underproduction. Mixing up those prefixes, it flips the entire clinical direction of your claim. This is also where we categorize major systemic conditions like diabetes mellitus. It's a primary pancreatic disorder, right? But it cascades into multiple systemic codes depending on if it's type 1, type 2, or if it has complex neurological manifestations. Now, when we talk about procedures, the exact anatomical source dictates the surgical code. Notice how that suffix ectomy, which means surgical removal, always pairs with the specific gland. You have thyroidectomy, adrenalectomy, pancreectomy. But here's a crucial insider tip. Coders have to meticulously read the operative note to catch whether it's a partial versus a total thyroidectomy. Removing just one lobe instead of the entire gland requires entirely different CPT codes. Honestly, missing that one tiny detail in the documentation will cost you the question. Section 3. Nervous system anatomy. Let's shift gears to the neurological network. To simplify this incredibly complex system for coding, I want you to think about it in terms of mainframe versus wiring. Your mainframe is the central nervous system, the CNS. This is your brain, with all its cerebrum lobes, the cerebellum, and the brainstem, along with the spinal cord. Now your wiring? That's the peripheral nervous system, or PNS. This includes the cranial nerves, spinal nerves, and the autonomic nervous system, which balances your sympathetic and parasympathetic responses. If a patient's chart mentions something like dysautonomia or orthostatic hypotension, you are coding for a dysfunction in that specific autonomic wiring, and that guides you to a totally different neurological subcategory. Section 4, CNS versus PNS coding. So why does this anatomy matter so much? Because confusing a CNS condition with a PNS condition is one of the most common traps on the entire exam. And this brilliantly illustrates why. Let's look at the pathology. CNS conditions include seizures, multiple sclerosis, strokes, and meningitis. You have to really scrutinize the documentation for these. Like, is that stroke ischemic, meaning there's a blockage, or is it hemorrhagic, meaning a bleed?
those map to entirely different ICD-10 blocks. On the flip side, PNS conditions include peripheral neuropathy and localized nerve injuries. Distinguishing an ischemic stroke in the mainframe from a peripheral nerve injury in the wiring is what drives your diagnosis coding accuracy.
Section 5. Neurological procedures. Let's quickly apply this to the surgical and diagnostic codes, where spatial specificity is your absolute best friend. For high-yield procedures, think craniotomy or laminectomy, the operative documentation must define the specific brain lobe or the exact spinal level. Is it cervical, thoracic, or lumbar? If a surgeon performs a laminectomy across multiple spinal segments, you absolutely have to know which level is the primary procedure so you know which subsequent levels require those bundled add-on codes. Same goes for a ventriculostomy or a diagnostic EEG. Knowing exactly where the hardware is placed or what part of the nervous system is being monitored is strictly required for accurate CPT selection. Section 6, Part 12, Cheat Sheet. We have covered a massive amount of ground today, so let's lock in all this high-yield info with a rapid-fire visual summary. So, the crucial point is right here. You can see exactly how the endocrine neck and abdominal regions map to their specific disorders and those ectomy suffixes. And right below that, check out how the nervous system strictly divides into CNS mainframe pathologies and PNS wiring pathologies. Seriously, take a mental snapshot of this summary matrix. Understanding how the underlying anatomy dictates these coding procedures is going to save you precious time on exam day. And that brings us to the end of today's explainer. Next time, in Part 13, we are going to do a fascinating deep dive into the sensory organs, covering eye and ear anatomy right alongside their high-yield conditions. Until then, I want to leave you with this thought. If a single prefix can completely flip a patient's diagnosis from a critical overproduction of hormones to a life-threatening underproduction, how many other tiny documentation details are secretly holding the key to your coding accuracy? Keep studying hard, and I'll see you in the next one.